Today, the case-based discussion is on a child with joint pains. A child presenting with joint pains is a fairly common scenario in day-to-day practice of pediatrics. The underlying etiology could range from a simple or a benign cause to a serious pathology. Therefore, it is important that the first contact doctor is capable of doing a proper clinical assessment and carry out a basic evaluation on such a patient. The primary objective of this case-based discussion is to analyze a common clinical presentation to provide you with a learning experience on basic evaluation of a child with joint pains. The overview of the presentation includes how to take a comprehensive history and then how to arrive at a reasonable differential diagnosis based on the clinical judgment. Thirdly, performing a basic evaluation. And finally, the principles of management of a child with joint pains. The patient for today's discussion is a 2-year-old boy who had fever over the past 2 weeks' duration, who was noted to be irritable during this duration and also disliked being handled by parents. The child refused to walk and also noted to have loss of appetite. And during the second week of the illness, mother noticed swelling of bilateral knee joints and ankle joints. Well, what else you may want to know about this patient? I will give you a few minutes to think of the questions that you would like to ask from the mother to come to a differential diagnosis. All right. In further questioning, the mother also complained of a transient pinkish skin rash which was noted at the height of fever spikes. The rash was not seen throughout the day. It was only seen mostly towards the evenings during this illness. All right, so we'll move on to the rest of the history. All right, what are the possible conditions that you could be dealing with in your patient? Could it be due to an infection? For an example, an acute viral or a bacterial infection, or could it be a post-infective phenomenon? Secondly, could it be an inflammatory condition? And also, will you consider a malignancy in this child? And also, you may consider an autoimmune or a vasculitic condition as well. Therefore, your history should encompass the features of all these conditions, and you will have to exclude one by one clinically and then narrow down your clinical diagnosis so that you can go ahead with a basic evaluation to narrow down your differential diagnosis further. What are the infective conditions that you would consider in this patient? A child presenting with joint pains could be due to a post-infective phenomenon like streptococcal infections or viral infections. So what are the viral infections that could lead to post-infective arthritis? Common viral infections like Epstein-Barr virus, cytomegalovirus, Kawasaki, hepatitis B, all could cause inflammatory arthritis in children. Bacterial infections like infective endocarditis, generalized sepsis, and even disseminated tuberculosis can lead to joint arthritis or arthralgias during an acute infection. Similarly, rickettsial infections like Rocky Mountain spotted fevers, Mycoplasma infection, and Lyme disease could also result in arthritis during an acute infection. Now, what is reactive arthritis? It usually follows gastrointestinal infections like E. coli, Shigella, which could lead to, again, it's a post-infective arthritis. Acute rheumatic fever is another condition that you may consider in a child who presents with multiple joint involvement. However, there are typical features like flitting type of migratory type of arthritis or arthralgias. Acute rheumatic fever is also a post-infective condition, but however, you may not consider this entity in the case that we are discussing today because acute rheumatic fever is common in slightly older age group, not in a 2-year-old child. Okay, now those are the common viral, bacterial, and other infective conditions that you may consider in this patient. Therefore, what are the clinical features or the symptoms that you are going to ask for in the history? For an example, the presence of a sore throat in the recent past may suggest that it could be a post-streptococcal condition. Also, the presence of febrile illness with a rash 2-3 weeks prior to the onset of this multiple joint involvement also suggests that the child may have suffered from a possible viral infection. Infective endocarditis, sepsis, those are quite severe infective conditions in children, so it may not pass off as a simple febrile illness in a child. So your patient could be acutely ill with high fever and other clinical manifestations for you to consider the infective endocarditis or sepsis in this patient. Also, rickettsial infections may have other clinical manifestations like a generalized skin rash involving palms and soles, which you may confirm in your clinical examination. Micropascal infection. They are community-acquired infections, generally affecting slightly older age group, but it can affect any age group. Therefore, you may consider this as well. And also, this is a multi-system involvement. So, in your examination, you may do a thorough systemic examination to consider this condition. Okay, moving on to autoimmune conditions. The most common disease entity that you may consider in a child who presents with joint involvement could be juvenile idiopathic arthritis. And to have a rash, systemic onset of juvenile idiopathic arthritis may be the most common condition that you may think of. In systemic onset juvenile idiopathic arthritis, you may expect very high fever spikes and also the presence of skin rash at the heights of temperatures, most commonly occurring towards the evenings. Right? So therefore, it may be applicable to our patient. So we will consider this and try to exclude by excluding other conditions mainly. And juvenile dermatomyositis, again, it's an entity which is associated with a lot of other skin manifestations which are involving the knuckles, extensor aspects, and also there may be a component of myositis. So that also can be considered, but generally they are more common in slightly older age groups. But however, you may consider in your differential diagnosis. SLE and other connective tissue disorders are more common towards an older age group in children. So therefore may not be applicable in a 2-year-old child. So what about the other vasculitic conditions like Kawasaki disease? So in a 2-year-old child, you may consider the presence of Kawasaki disease with multiple joint involvement, but you all know there are criteria to diagnose Kawasaki disease. So you may have to take a history and also examine to look for other features of Kawasaki disease like cervical lymphadenopathy and other mucocutaneous manifestations like non-purulent conjunctivitis and red lips and so on. Inflammatory bowel disease is also well known to be accompanied by arthritis, but however this age group is not very compatible with initial presentation of an inflammatory bowel disease like Crohn's disease. Henoxian line purpura is associated with a typical skin rash, and also they may complain of severe abdominal pain, and you will have to perform a thorough examination to rule out this condition. Would you consider a malignancy in this child? You all know certain malignancies in childhood like acute lymphoblastic lymphomas, and neuroblastomas may also present with joint involvement at this stage. So you will have to have a thorough clinical evaluation to rule out malignancies in a child who present with multiple joint involvement. Based on all these that we considered in the previous slide, now you may understand what further history. Now let us move on to the examination of our patient. On general examination, this child was ill-looking on admission, febrile to touch, was irritable when handled, especially when handled. He didn't appear pale, he was not icteric. He had lymphadenopathy, which was primarily cervical and axillary, lymph nodes measuring 1 to 2 centimeters in size, discrete lymph nodes. There were no skin rashes or nodules, not edematous. He was noted to have swollen joints at both knee joints, ankle joints, and right side wrist joint. Proximal interphalangeal joints were also found to be inflamed. He did not have muscle tenderness, and there were no bleeding manifestations and no bone tenderness. So these are the findings on general examination. So let us see what were the findings on systemic examination of this patient. His pulse rate was 96 beats per minute with a blood pressure of 80/65 mercury millimeters. The heart was in dual rhythm and there were no murmurs. Respiratory examination revealed a respiratory rate of 22 per minute with good air entry and clear lung fields. Abdominal examination showed a non-distended abdomen with mild generalized tenderness, hepatomegaly of 3 centimeters, firm hepatomegaly with smooth borders and no nodules, firm splenomegaly of 2 centimeters. Musculoskeletal examination revealed swollen joints, which were described in the general examination. They were having features of inflammation, red, warm, and tender, with restricted movements. However, there was no neck or back pain or tenderness, and no muscle wasting or tenderness as well. Central nervous system examination revealed a conscious child who was alert, comprehensive, and the cranial nerves were normal. Okay, so these are the findings on systemic examination of the patient. Now let us summarize this patient in the next slide. So this is the summary of our patient who we are discussing today. A 2-year-old boy with 2 weeks history of fever, joint pains, and loss of appetite. Examination reveals an ill child with polyarthritis involving large and small joints, lymphadenopathy, and mild hepatosplenomegaly. He also had a skin rash which appeared at the height of temperature in the evenings. Now let us consider the most likely differential diagnosis based on our history and examination. So, see what you have considered in your differential diagnosis, whether it tallies with the conditions that I'm going to produce in the next slide. All right, now let us go back to the same slide where we considered the multitude of possibilities that are likely in our patient. So we considered infections, acute as well as post-infective phenomena, viral, bacterial, and other infective etiologies. So what is possible in our patient? And then all these infections and post-infective causes lead to inflammation, leading to either a post-infective or a reactive arthritis and acute rheumatic fever, and the other inflammatory conditions caused by various kinds of vasculitis like Kawasaki disease, inflammatory bowel disease, Henoxian line purpura, right? So with the available history and the examination findings, now we can arrive at a more clinical judgment to think of the most likely differential diagnosis. We also considered certain autoimmune conditions, including systemic onset JIA, Juvenile Dermatomyositis, SLE, and other connective tissue disorders. Now, with the available clinical signs, we can now narrow down our differential diagnosis. We also considered malignancies like acute lymphoblastic leukemia and neuroblastoma. Okay, now with the clinical findings, what are more possible in our patient? Now, did you also come out with this list of differential diagnoses which are likely in this patient? Firstly, systemic onset juvenile idiopathic arthritis. Why should we consider this condition? It's because although the duration is still 2 weeks, there has been fever for 2 weeks already with multiple joint involvement, with evidence of arthritis in this child, an evanescent rash, erythematous maculopapular rash appearing with the height of temperatures towards evening. We may consider this condition because the age is also compatible. Acute lymphoblastic leukemia, again a 2-year-old child, hepatosplenomegaly, right? And lymphadenopathy, it's a condition that we need to exclude. So what about poststreptococcal arthritis? Because it's very common in children, although we could not find a recent history of sore throat in this patient, we may consider this, and we'll have to exclude by basic evaluation. And any viral infection is still possible in this patient, because viral infections are very common and it can lead to polyarthritis as well. And there could be associated hepatosplenomegaly, especially in cytomegalovirus and Epstein-Barr viral infections. We may expect this. All right, so now we will get on to a basic evaluation to further narrow down this differential diagnosis, so that at the end of our evaluation, we may be able to arrive at a more likely diagnosis in the patient. All right, what are the basic investigations that we should perform in this patient? Obviously, a full blood count. What should we expect in the full blood count? Now, these are the results that we have got in our patient. The white blood cell count of 21,000 with 75% of neutrophils. So what does that indicate? There is ongoing inflammation in this patient. It could also indicate that there is a bacterial infection. And the platelet count is 526,000 with a hemoglobin of 9.5 grams per deciliter. The increased platelet count indicates an inflammatory condition. Similarly, the neutrophil leukocytosis with slightly low hemoglobin and high platelet count, the combination indicates that there is a chronic inflammatory process. Now, what are the inflammatory markers we can do on this child? The C-reactive protein, which is found to be 105 in this child, and an ESR of 80. So both of them support an inflammatory condition. But the CRP of 105 may indicate an infection as well. Therefore, we need a blood culture to rule out a systemic infection. The blood culture did not reveal any growth in this child. So another important investigation is a blood picture, because we have found a low hemoglobin. We need to see whether what is the cause for low hemoglobin. Could it be a malignancy? Could it be a chronic inflammatory process? Or if it's an infection, it may show the neutrophil response and the left shift, right? Septic features may be revealed in the blood picture. So what have we found in our patient? It's a normochromic normocytic anemia, which favors more of a chronic inflammatory process. And there is reactive thrombocytosis as well, which is also in favor of chronic inflammation. And in addition, the blood picture did not reveal the presence of any abnormal cells. Therefore, a malignancy is unlikely and an infection is also unlikely. Okay, right, so we'll move on to the next step. Now, what are the other investigations we could do to rule out our differential diagnosis? Now, although our blood picture did not reveal any abnormal cells, we haven't excluded the neuroblastoma yet. And also in leukemic conditions, the blood picture may not reveal abnormalities initially. Therefore, an ultrasound scan abdomen may reveal further information. So what are the ultrasound scan findings of our patient? Ultrasound abdomen confirms moderate hepatosplenomegaly in our patient. It also shows that the hepatic architecture is preserved with no intra-abdominal lymphadenopathy or masses. Now we can safely rule out a leukemic process and also a neuroblastoma. But however, neuroblastoma is still not 100% excluded. Right? So let us see what else we could do to rule out this condition. The chest X-ray did not reveal any mediastinal widening, therefore mediastinal lymphadenopathy is basically ruled out. ASO titer, negative ASO titer rules out the possibility of a poststreptococcal phenomenon. And Epstein-Barr virus and cytomegalovirus serologies are negative. Therefore, a viral post-infective arthritis is unlikely in our patient. ANA rheumatoid factor are both negative, but however, they may be negative in systemic onset JIA. Eye assessment for anterior uveitis have to be performed when you consider a juvenile idiopathic arthritis which were negative in this patient. But you may know we expect to be anterior uveitis mostly in oligoarticular arthritis. 2D echocardiogram revealing the absence of vegetations and no pericarditis. Okay. Absence of vegetations rules out the possibility of infective endocarditis. And pericarditis is important in the evaluation of a child with systemic onset JIA to see whether there is pericarditis, because the serositis could be associated with this condition, but however, in this patient, there is no evidence of pericarditis. MAN2 is negative because we consider disseminated tuberculosis in this patient. Okay, so the second line investigations now rules out some of the conditions that we have considered in our scenario. Now let us talk about further investigations of this child, or the third line investigations. We need these more specific investigations to arrive at the exact diagnosis for our patient, because there are important conditions that we need to rule out. Lymph node biopsy did not reveal any abnormal cells. They were reactive, right? So, and then the bone marrow aspiration is important, especially to rule out a neuroblastoma in this patient, which again was a reactive marrow with no features of a malignancy. So now basically we have ruled out the possibility of acute lymphoblastic leukemia and neuroblastoma. We have also done a serum ferritin level. You all know it's an acute phase reactant as well as inflammatory marker. So serum ferritin is elevated in this patient, indicating that there is a chronic inflammatory process. We have basically excluded the infective causes. So now high ferritin level is suggestive of a chronic inflammatory process. We have also done a urinary VMA level, which is negative. It is a marker of a neuroblastoma, right? So now I think almost 100% we have ruled out a malignancy. CT scan abdomen also revealed no suprarenal masses or paravertebral masses. All right, so now are we able to arrive at a most likely diagnosis for our patient? Now let us see. Now while we were investigating, the child arrived at the 4th week of illness. The key features that we found during the 4th week of this patient were persistent fever, remaining polyarthritis, and appearance of erythematous rash with the fever spikes, lymphadenopathy, hepatosplenomegaly which were persisting, and now we are left with the investigation findings of neutrophil leukocytosis with elevated inflammatory markers, and we have excluded an infection and a malignancy. So now, what is likely in our patient? So I think it's quite clear for you now that there is no infection in this patient, there is no malignancy, right? So what is more likely? Well, by excluding all the other possible etiologies, now we could arrive at the most likely diagnosis, the systemic onset juvenile idiopathic arthritis. It is actually a diagnosis by exclusion. There are criteria to diagnose systemic onset JIA, so we look at them in our next slide. Systemic onset juvenile idiopathic arthritis is an exclusive childhood condition, and it is a chronic inflammatory disease with remissions and flare. So this disease entity is characterized by polyarthritis, which lasts at least 6 weeks, involving both large and small joints. Fever has to be there for more than 2 weeks, which we saw in our patient, with an associated rash, lymphadenopathy, hepatosplenomegaly. Serositis, however, we could not elicit any serositis in our patient, and we need to exclude other treatable conditions like infections and malignancies, which we have done in the patient. So you all know, at the 4th week of illness as well, the child was continuing to have fever and polyarthritis, and we have excluded the possible infections and malignancies by extensive investigation. Therefore, one can safely arrive at the diagnosis of systemic onset of juvenile idiopathic arthritis. Okay, how are we going to manage this patient now? The principles of management would be to induce remission and then continue to maintain the child in remission. And at the same time, we need to aim at preventing joint destruction and long-term joint deformities and things like limb shortening. And also we need to achieve normal growth of the child, normal height potential. We need to minimize the drug side effects because our patient will need treatment with drugs with various side effects. And finally, our final objective is to improve the quality of life of the patient. All right, so those are the objectives of the management of a child with systemic onset juvenile idiopathic arthritis. So what are the medications that we can use to induce remission in this patient? If it's a mild disease, we can utilize non-steroidal anti-inflammatory drugs like naproxen or ibuprofen. If the disease activity is moderate, the child will need a systemic steroids with slow tapering of the steroids. And if it's moderate to severe disease, one might consider using a biological disease modifying anti-rheumatic drug like anakinra. So the agent that we use to induce remission varies with the disease severity. So once the remission is induced, we need to maintain the child in remission. So what are the drugs that we can utilize to maintain remission? The most common agents are methotrexate or leflunomide. We call them disease-modifying antirheumatic drugs. When a child is on these drugs, they need to be monitored for the drug-related complications. While we are treating with medications, a patient with juvenile idiopathic arthritis will need a lot of supportive therapy in terms of physiotherapy and occupational therapy. And also, we need to consider the nutritional aspects of our patient. They can develop osteopenia, early onset osteoporosis, so they may benefit from treatment with calcium and vitamin D. So long-term follow-up is needed and we need to arrange that, and they have to be monitored for disease-related and treatment-related complications. While we are treating a patient with systemic onset of JIA, we need to be aware of the most dangerous complication, which is the macrophage activation syndrome. Macrophage activation syndrome is characterized by falling of blood counts which were initially elevated, falling counts of platelets, and at the same time elevation of liver enzymes, marked hyperferritinemia going into many thousands, evidence of coagulopathy, and sometimes CNS disturbances. If a child who is being treated as for systemic onset JIA develops these clinical features and laboratory investigation findings, we have to be very careful because macrophage activation syndrome carries a very high mortality and needs vigorous treatment. Okay, right. So we have gone through the basic principles of management of a child with systemic onset juvenile idiopathic arthritis. In summary, today we did a case-based discussion of a 2-year-old child who presented with fever and polyarthritis. So we considered the age-related possibilities and arrived at a broad differential diagnosis considering the infective etiologies, inflammatory conditions, malignancies, autoimmune and vasculitic conditions. And with thorough history and examination, we were able to narrow down the differential diagnosis, and with basic and further evaluation, we were able to arrive at a diagnosis. So that is how we would analyze a patient with joint pains. And finally, we discussed a few things about the systemic onset juvenile idiopathic arthritis, and I also went through the basic principles of management of systemic onset JIA. So that concludes today's case-based discussion. Thank you.